today. So I will turn it over to talk about surgical management of TGCT.
Yes, thank you very much for the great organization, and thank you very much, Emanuela, for your talk. And if you think that there are big differences between the medical oncologists and the surgeons in Essen, where I work, you will not be successful. We in most cases agree regarding the treatment. I think this is very, very important. I have to sit, otherwise I cannot. My back. My back. So surgical management, and I will explain my surgical thoughts regarding this great consensus paper which was published, and I think this is a very, very good paper. And in most topics, I would agree. Perhaps in some topics we realize that there are different opinions which could be seen in the conclusio, if I can say. But I will make a comment on this. Epidemiology, we already heard from Emanuela. Let me say only one thing. If I hear the incidence, I think, as you said, it's even much, much higher. I would say, as an tumor orthopedic surgeon, each 2 weeks, I get a call from an arthroscopic surgeon from elsewhere. He said, "Oh, I did an arthroscopy. I removed something. It was a TGCT." In my opinion, they are not all included in our databases. I think it's definitely higher, the incidence. Radiology, I think most of the patients with knee pain get an MRI, and they come perhaps first to orthopedic surgeons or even conservative orthopedic men. And MRI with contrast medium is very, very important. And what is also important, that if you make follow-up examinations, we try that the MRI is done by the same radiologists, so that you can compare the pictures better. Otherwise, you have always other sequences, and you have discuss. So this is, in my opinion, very important to have one radiologist. And then we are in the era of PET-CT, PET-MRI. This is written in the paper. It has no role in a giant cell tumor of the tendon sheath. And now is coming a question. I'm doing now 24 years tumor orthopedic oncology. What is with biopsy? I was learned that we have to do a biopsy in a patient with a suspected diffuse type tumor. We did in all of these cases 20 years ago a biopsy first. Nowadays, in my center where I worked, I was educated in Münster, then we are now in Essen. First, we did a biopsy. But nowadays, and this is how it is written in the paper, and I totally agree, the MRI is so clear in often these cases that we have written in the paper, and we would recommend it also. But either you do a biopsy or you make perhaps if the radiology is highly suggestive of a TGCT, we can make first the resection. This means arthroscopy or open, you have said. Normally, as a surgeon, we would take the ventral part. In diffuse type, you have ventral part of the tumor and a dorsal part. And for the surgeon, it's much easier to go the ventral part. The dorsal part, there are big vessels, and we should not forget that all of the surgery of diffuse type of the dorsal part is not without risk. And I see some patients who were treated elsewhere. Yeah, we do it dorsally, and then you have a vessel complication or something else. Believe me, as a tumor oncologic surgeon, sometimes it's for me more difficult to do surgery in this benign tumor than in osteosarcoma, where I have a better view of the vessels and everything. So we should not forget that surgical surgery is not always easy. So what is important? We need a biopsy, or even we make a resection of the ventral part, and then we obtain the diagnosis of the tumor. And what is also important, what we have to know, that sarcomas located in the knee joint are extremely rare. Real soft tissue sarcomas of the knee, we published it from Münster. We had 12 cases in 20 years. So normally it's like this, or differential diagnosis, for example, chondromatosis of the knee joint. Example, 41-year-old man, suspicion of a diffuse type. You see the dorsal part. This is not, everything is not tumors. You have often ganglia, Baker cysts, etc. together with a tumor. And we decided here the patient has pain in the ventral part. He has problems with bending, with flexion of the knee. We did an arthroscopic synovectomy, and honestly, the dorsal part, which was mainly cystic, he was asymptomatic. We left like this. Active surveillance. This is also, I think, surgeons have to be. Not always you have to do surgery in these cases. So I totally agree with this. Not all of these patients have to be treated. But here, the diagnosis was obtained by arthroscopic surgery. Second case, 43-year-old man. Here we had, of course, a highly suspicion of a diffuse type 1. You see here in the ventral part, you see here in the dorsal part. And all of these patients should be done. We are a team with oncologists, with radiologists. We discussed this case before in MDT, and we were in trend to make a medical treatment. And the patient had pain, but it was not so much in the ventral part. And then we decided to make a biopsy, so that our oncologist, Professor Sebastian Bauer, then treated him with a medical therapy, and it is successful. The pain decreased, and then I don't need the surgery here in this case because the patient is fine, and quality of life should be in the center of our thinking. Third case, 44-year-old man, nodular type, and here, in my opinion, you already said the low local recurrence rate. We do it nowadays. I was trained 20 years ago that we have to make it open. A small mini open incision so that you can remove the tumor. Nowadays, I'm honest, I'm not an arthroscopic surgeon, I'm a tumor oncologic surgeon, but we have good arthroscopic surgeons, and they remove it en bloc without shaving, without parcellating it. This is very, very important. And if you have a good arthroscopic surgeon, and then you have the local recurrence rate of 10 to 14%, and we treat most of them because here the patient has a problem of flexion of the knee, and therefore it makes sense to do surgery. And low local recurrence rate, and normally the patient then has no problems anymore. And here, of course, you can say it's clear hardest, it's a diffuse type giant cell tumor. I was not sure. You see, of course, it's in the joint, but you see here the patella tendon. You see here the big tumor. I was not sure if this would be a soft tissue sarcoma. This is an indication clearly for a biopsy, and we were happy that it was a giant cell tumor of the tendon sheath. So let me say surgery, it is most important, as you said, we should do surgery if we are able to get the tumor out. If we, as surgeons, at a nodular type, it's mainly possible. If we are not able to put the tumor out, especially in diffuse type, there is a question of other things. And this is written in the consensus paper, in my opinion, very, very good. And the sentence, the value of debulking surgery is controversial and should be balanced against other therapies, is very, very important. Because we have in Germany at least some surgeons who make very risky surgeries, debulking surgeries, they never could get it out because it's diffuse, especially in erosive changes and so on. So I think this is very important, and I always cite this paper now. Please do not do surgical overtreatment in these cases. And then there is another question: if you do it by arthroscopy or open. I was learned in diffuse type to make it open. But we should never forget, if you make an open synovectomy, first, as a surgeon, open. You sometimes are not so good as an arthroscopic surgeon. If he's good, of course, he has to make a complete synovectomy, but he can come with the arthroscope behind the cruciate ligament. He can see it even better than me as an open surgeon, let me say. And we in Essen make it now, I have to be honest, mainly arthroscopically and only open in selected cases. The dorsal part, of course, we have to make open. There you cannot make arthroscopy if it's needed, if you have symptoms. If you have no symptoms, active surveillance or medical therapy is an option, in my opinion, in these cases. And again, MDT, MDT, MDT. It's teamwork. So here you see this. This is a nodular form. This you can resect. This is here a diffuse form, only ventral. Yes, you might resect. But this case here on the right, diffuse form, you never could remove it completely. It's not correct if a surgeon tells it to you. The risk of local recurrence, Emanuela already said, in nodular low. In diffuse type, yes, it's high. It's definitely high, and perhaps it's a little bit lower with open one, but in my opinion, the era is going more and more to arthroscopic resection also in diffuse types of the ventral part of the tumor. And this is, thank you that you mentioned it. Honestly, I do it longer than 10 to 15 years. I have so many patients who have no problems with the tumor. It's stable. It's a stable disease. They have no problems. And then leave it like this. Don't make cosmetics of MRI. If there is a small recurrence, leave it like this. And if I heard 6 arthroscopic resections, asked if the patient had complaints or wait, a little bit more calmness. I think it's better. So we are a little bit more to active surveillance in asymptomatic patients. In symptomatic, of course, we have to take into account surgery or medical therapy. Here, 54-year-old woman, hip. You see the big tumor, hip joint, the hip, and the pelvis. Of course, you find a surgeon who says, I resect it. But believe, with imatinib, this was the best choice. You see how small the tumor is. She has no complaints. Do not do surgery. This is my task. And here we did a stop of imatinib since 2021, and it's stable now. We do not do anything now, and the patient is pain-free. Perioperative therapy, you already said, we discuss it. This is, I think, not completely clear. Makes it sense to make neoadjuvant, adjuvant the setting of medical therapy? I think there we need more studies to look what. I think the story is not completely finished there, but again, we have to be in contact with our oncologists. Follow up. This was a hard discussion. So, in my opinion, if you have a stable patient 2 or 3 years and nothing happened, you don't need each 3-month MRI. If you have a more active patient or under medical therapy, you need it, of course. But I think sometimes there are too many MRIs in asymptomatic stable patients. And I am often asked, nodular form, resection was done. 14% local recurrence. We make 2 or 3 years, we look. And if there is nothing, we stop it. And if there could be a recurrence, you will get pain again, and we look. In my opinion, there is sometimes an over-diagnosis with MRI. And here you see the teamwork approach. This was a diffuse type giant cell tumor of the tendon sheath, and we did a ventral arthroscopic resection. The dorsal part we left. He got imatinib from Professor Bauer. But then he got a recurrence, a very huge recurrence in the ventral part. The disease is sometimes crazy. Don't ask me why. And it's like this. And then we did the surgery open. This we did open. But also here you have to keep in mind, if you make an open synovectomy, it's a big scar. It's often a very bloody thing. You have a lot of joint effusion. The patient has a long time problems if you make it open. But here we had no other choice. We resected it. And you see here the resection. Whereas the resection here is good. You see here a little bit effusion 1 year later, and he is now with imatinib again because of the dorsal component. And we talked to him. We could make the dorsal part too, but he's pain-free with imatinib. And then I do not like the dorsal one. You realize I'm a little bit more conservative regarding the dorsal ones. I know that there are a lot of surgeons who like this, but I'm more conservative there. I think the patient has to stay without harm in the popliteal region. So escalation versus de-escalation, there is no either or. I think we have to work together. We have an interdisciplinary approach, and we have, again, today, my presentation, patient's participation. The patient has to decide with us. We have not all of the truth, and we have individual therapy decisions. Let me say, perhaps active surveillance, medical therapy, surgery, yes, but not in all cases, and we have to talk together. Thank you very much for your attention.
Thank you, everyone. That was lovely, and it's so refreshing to have a conservative surgeon. I don't know if those always go together. So it's lovely to hear it. We are a little bit ahead, so if anybody would like to take a break or use the restroom, please feel free. You want to give like 5 minutes? Sure. Yes. I mean, we'll have a discussion session, but please feel free to ask questions. They're here. Yes, Erica.
The medication. Do you know why some countries, like for example, I am in Denmark, the doctors are not giving us any medication like Immunica or
This is more a question to the medical oncologist. One sentence, one last sentence regarding radiosynoviothesis. This is very important because this is in Germany done very often in not big centers. But this is in the paper clearly said, no radiosynoviothesis. And then I have to, you want to answer?
Yeah, no, I just wanted to um, to to tell that in Europe we have no approved drugs, so we either put patient in clinical trial or we sometimes can ask off-label use. But of course, it requires work and it requires the hospital paying for that. So it depends on the expertise of the hospital. So because we have no drug approved yet. That's the problem. No, nobody can use approved drugs. We can put the patient into clinical trials or ask compassionate program. Sometimes after, for example, pexidartinib was sent to EMA, they had 1 month of a compassionate program or off-label use. But it's not always easy. Depends on the expertise of the center.
Off-label means it's a drug that wasn't approved for the use. So it's just a specific. You want to ask? Yes. Yeah, imatinib is, yes. So Sebastian Bauer would be the wonderful doctor I would recommend in Essen to talk to about imatinib use.
Okay, thank you. For a child, like 9, 10 years, okay. Just made it synovectomy, okay. Excuse me, my English, okay. I speak 3 language and it's difficult. And now, the first step, if he will return, what I have to do, open or synovectomy? Because it's hard to...
Medically, I ask you or you, let me say, this tumor is, I'm not sure how often it is in children. We see it relatively often. It's not often, it's very rare, but we see it because we are a reference center, I would say 5 to 10 times per year. And these are difficult decisions because you already mentioned the question, what happens if you leave some of the tumor inside in diffuse type? Do I get an arthrosis or secondary erosive changes? And in my opinion, also this story is not completely finished. In my opinion, if I have a stable disease of this tumor, the patient is relatively pain-free, no big effusion. I would, from the orthopedic side, say, why should the cartilage get damaged? I would make more follow up there. And if I see that I get a cartilage damage, I would be more aggressive first. Second, what I do in children always, I involve our pediatric rheumatologists. Because sometimes it's not this tumor because it's then autoimmune disease, synovitis of another topic. Because you have to see in children especially we have much more rheumatism than this tumor because it's very rare. But if it's like this, of course, we can diagnose it then I would in children do the resection if I can do. I would do the resection if I can do, but if I see, and mainly in my opinion, in children, it's not so diffuse. It's not so diffuse. I would make more surgery. I'm not sure, do these medicaments are for children?
In fact, all the clinical trial are adults only clinical trials. Of course, we have some doses for kids, but usually keep waiting. So active surveillance would be the first choice also for a medical oncologist. Of course, sometimes quality of life in terms of playing on doing physical exercise is very limited. So in specific cases, some active treatment might be discussed off-label, for example, in grown enough children, but the approval might be more tricky because the data are all based on adults.
And again, you know that there is a disease, and here I would say make MRIs in a good follow up. And if you see there's progression, there's effusion more, there is joint destruction, then I would be more aggressive. But otherwise, also in these cases, in my opinion, active surveillance is possible, and perhaps it's a self-limit. Active surveillance is, in my opinion, therefore partially successful because perhaps it's a self-limitation of this disease also. So I do not recommend over-treatment, you know. I would not say, I do not recommend even in children over-treatment, and I would not say that all of these patients get an arthrotic disease. This is not true. You have to look after it, but I would not say 100% arthrosis of the knee or the hip.
Your experience, can we ask?
You give it your way. Yes, please.
I think I speak English more. He has swelling. Okay, he's playing football. Okay, player football a lot. 7 days with on 7. Okay, now he's doing well after not even 6 months. I think there are 5-6 months after surgery. And he's doing at on a surgery traumatologic surgeon. It's the doctor is Memeo on Pini, on Hospital Pini. He's yes, they told me that is a disease, benign disease. Okay. I didn't know what because in the first minute they think that was idiopathic arthritis, idiopathic. Okay, the first thing that they think about him, and then after 2 weeks in hospital, they found this disease, and they made a surgery, arthroscopic. A doctor, traumatologic, Dr. Momeo, okay, on Pini. They told me that after 2 weeks it will be okay, but it wasn't like this. It's much longer, okay, and now there are 6 months that it is okay for now. It was swelling. After 3-4 months, he felt like a crack on the knee, and he started to swelling a lot. I was very scared, but now it's okay now. But I'm very, very scared about.
But very important again, reference center. I'm honest, I'm no arthroscopic surgeon, but we have the knowledge because we in the reference centers treat these patients. And this is nothing against the arthroscopic surgeon who did it, because technically they are very, very good, but they need the scientific background.
I'm curious about the second bambino. Oh, yeah. Ah, okay. Okay. Okay, so thank you. Just much better.
We also, TGCT Support, started a project in minors. We have 135 kids under the age of 12. And so we're starting a project now in that. One thing is within our consensus, we kind of skipped over kids because all of the considerations. So we're hoping that will help with that situation too.